Okay, ladies and gentlemen, we move on to the next topic, which is medical emergency, and we've got Professor Ekanayaki to give us the talk on. This is related to section 1.2 of the syllabus. So without further ado, Professor Ekanayaki. Thank you.
Good morning, everyone. I'm going to cover the medical emergency, which is a very important topic, regardless of whether you are a general practitioner or whether you are a surgeon or whatever it is. It's very important to know the medical emergencies. So let's talk about the incidence of medical emergencies. Most of the time what you'd encounter is syncope, just straightforward faint attack. That's about 50% of all the cases of medical emergencies. And then of course angina would be about 8%, and seizures 5%, asthma 5%, 4 to 4.5%, and then you get cardiac arrest, anaphylaxis, and MI is about 1%. Thank you. So it's important that we do not, why are we not seeing many medical emergency situations in the dental practice is because we assess the patients properly, and then we limit our surgery to patients who don't suffer from any serious medical conditions. So if you recognize these patients and avoid treating them, you are safe. But if you don't take a medical history, you become negligent as well, and you encounter a serious medical problem. So what they say is, if someone has ASA4 status of a patient's medical history, medical condition, I think we should not do any elective dental treatment. So what are these ASA4 status? Is MI within 6 months, cerebrovascular accident within 6 months, anyone with unstable angina. What I mean by unstable angina means pain sometimes at rest, not pain when you exercise. That's a stable angina. Someone who has got a very fragile, brittle diabetic status, uncontrolled diabetic, or someone with very high blood pressure. I'm talking about very high. It's not 150 by 100 is not very high. I'm talking about anything above that. It's quite a high blood pressure. You could have problems, and in fact it can cause some bleeding as well. So these conditions, these emergencies are rare in dental surgery. In a general dental practice, a practitioner might see 1 or 2 life-threatening conditions, emergencies in their lifetime practice. Remember, elderly population is increasing because thanks to the medical advancement of medicine, anesthesia, and everything. People tend to live for 80s, 90s nowadays, so they have a lot of comorbidities. They suffer from various medical conditions that you have to be worried about. And 50% of these emergencies occur during the local anesthetic procedure. Remember that that's a painful situation for the patients. That's where all these, flight and fight status gets stimulated, and patients can have some sort of a medical problem at that time because of the pain. So it's very important that you do a very good pain control. You talk to the patient, reassure the patient, use all these methods to control the pain, topical anesthesia, use fine needles, give the local anesthetic very slowly, and things like that. And sometimes best thing is to lay them flat when you give a local anesthetic, because if someone has a propensity to get a syncope or faintish attack, it's better to keep the brain at the level of the heart, so you have a higher blood supply to the brain. So when such a thing happens, a medical emergency, what should you do? You should have a very good concentration about the situation. You should assess the situation, so it's no point panicking. You have to face the situation. So stay calm, think clearly, and act promptly. So you have to treat the unconscious rather than the cause initially. Someone could have a myocardial infarction, someone could have anaphylaxis, someone could have hypoglycemic attack. You are not trying to treat that first. Unconsciousness is the problem where it causes lack of blood supply sometimes to the brain, causes problems. So assess the patient and recognize the condition. I'm not going to go into CPR. You will be dealing with CPR in a very different level because it's a compulsory, mandatory station in the MFDS as well. So I'm just going to tell you some certain changes in the CPR. 2015, there are 2016 guidelines. No, not major difference between 15 and 16. Usually the ABC has been changed to CAB now. So what they talk about is compressions, because that's the most important thing, to give the blood supply to the brain. So if unresponsive, you are not breathing, start compressions, and then you go to airway and breathing. ABC, traditional ABC, causes significant delay, about 30 seconds in starting chest compressions. So that's critical what they say is. Remember that all this is like in any science, evidence might change. In 5 years' time they say, I am talking here nonsense now. It might say ABC the best. That's how it is. That's science. Okay, evidence changes. What we do today may be totally wrong in few years' time. So compressions about 100 per minute and deep at least 2 inches. So it should be quite a good compression. And if you have a trained person with you, you do 30 to 2 rate CPR, compressions and breathing. So it's CAB. And remember, in your practice, you must have an emergency kit. It should have everything what you will need in a situation like that. And that emergency kit should have certain things, important things like oxygen delivery system, an airway, a stethoscope, sphygmomanometer, AED, automated external defibrillator, glucometer, spacer for giving the inhalations, syringes and needles, alcohol wipes, tourniquet, gloves, gauze, cotton wool plasters, and a good suction. So this is an AED. Nowadays the AEDs are very easy to use. Once you buy one and you follow the instructions, and then you get used to that, it will tell you where to place the leads and when to do it will recognize the pattern of the cardiac the rhythm, and then it will tell you when to give the shock. So it's not like those days. When I was an intern, I didn't have a clue what to do at that time. And all these defibrillators are huge, big defibrillators. It's made life much easier. And these defibrillators are available in every place nowadays, in airports, in a lot of public places. And as a dentist, it is a must that you should have, that will save a life, and you will not be negligent. At least if you have it, you try to use it rather than say, well, I don't have it. So what are the medications that you should have? First thing, you need to have oxygen, and you should check it monthly for leaks and pressure. If you don't have enough oxygen, there's no point. Sometimes we have oxygen cylinder which is expired and it leaked and there's nothing left in. Adrenaline, that's next life-saving thing, is 1 in 1,000 adrenaline vials or injections. Aspirin 325 milligrams in a case of a stroke, MI or something like that. Glucagon 1 milligram for hypoglycemic situation. GTN 0.4 milligrams. Remember, it has a shelf life of only 3 months. You keep it in a brown bottle or something like that if it is not in a box or something. Best thing is to have a spray which is much easily absorbed as well. Glucose 50 ml of 50% tablets or glucose solution. Salbutamol for asthmatic attack. Hydrocortisone 100 milligrams vials. Chlorpheniramine 10 milligrams for any kind of allergic situation. Midazolam or diazepam and water for injections, and check for expiry dates all the time. So what I'm going to do when someone collapses, first thing you do is stop the dental treatment, head down, feet up position. You change the chair, you check for the pulse, check for the respiration. If there's no pulse, no respiration, you call for help. Start cardiac massage, continue CPR until help arrives or patient regains consciousness. And then you get the defibrillator if it is indicated, and get the patient assessed by placing the defibrillator. So let's deal with some of the important medical situations, emergency situations, starting with syncope, which is, as I said, it is about 50% of all the medical emergencies that you will encounter. Patients, it's just a scary situation for the patient, sometimes embarrassed, high stress situations, and pain, unwelcome news, and all these things can cause a syncope attack. There's a short loss of consciousness and muscle strength, and patient collapses. And the thing is, there's a rapid onset, rapid duration. It lasts, short duration, and the recovery is rapid. Remember these three things. Starts fast, stays for a short duration, and recovers quickly. Recover quickly, remember that. Prodromal symptoms like they go pallor, and sometimes they might say, "Doctor, I'm not feeling well." They get a lot of sweating, diaphoresis. Mid-rise is the pupil becomes dilated. I always look at the patient's expressions and patient's response to my talk and everything like that. You should always talk to patient during any procedure, time to time, reassure the patient what's going on. With that, you can always see what the response is. Patient is going to faint. First thing you will see is they don't blink. They go like that and staring at something, and the next thing, bang, gone. So they might say they feel warm. They might say they have kind of nauseated feeling. They have a lot of salivation and dizziness. As I said, always look for eye signs. So what do you do in a situation like that? You put the patient with the legs elevated, supine position, and the head down positions. If the patient is a pregnant patient, you might not do that. You might ask the patient to lean forward and put the head between the knees rather. Maintain the airway. Generally, remember, when you do that, they recover so quickly. That's where you recognize any other condition. The recovery is probably 20 seconds. And they open the eyes and they respond and they say, "Where am I? What happened?" This and that. You reassure the patient. When that does not happen, there is something else going on. Remember, if it is delayed recovery, you should think about hypoglycemia. Is it a cardiac event like a cardiac arrest, or is it a stroke? Or it could be psychological as well, remember, like hysteric patients. If vomits, you suck the vomiters and put the patient in semi-prone position, and remember they should not drive for about 24 hours. Cardiac arrest. In a cardiac arrest, the most important thing is reducing the time it takes to locate an AED is the key to success. So you should have trained your staff. You just say AED and they should bring it in a second, okay? If an AED applied within the first minute of a collapse, the chances of recovery, what they say, is about 90%. So AED is the most important thing. For every minute that passes, their chances of survival goes down by about 10%. Remember, majority of these patients have no cardiac history at all. Remember, they may not have angina or anything like that. And you don't really have to have angina to get a cardiac arrest. That's the thing. So they could be otherwise fit and healthy by talking to you, and they will give you a very good medical history. Sudden collapse, there's no response, no breathing, no pulse, call for help. If no help, you start hands-only CPR. That's only effective for about 5 minutes. It says average about 16 seconds to deliver 2 breaths. That's why there is a tendency to go on compressions. Do it as quickly as possible and get AED within 4 to 6 minutes, even fast if you can, because that's the time the brain damage occurs. Myocardial infarction. Classic, the patient says, doctor, I'm getting pain here, and they show this compression type of compressing pain. They do that. This is called the Levin sign, compression, and they put it on your sternum, middle of the sternum. They say, doctor, I have pain here. They get breathlessness. They get a lot of sweating, huge amount of sweating. It's not just, it's like after doing a strenuous exercise, you'll see the sweat pouring. They get no relief from GTN. If it is angina, there's relief from GTN. Position comfortably, semi-upright position, give GTN, aspirin 300 milligrams, ask them to chew and swallow, monitor vitals and oxygen. Remember, semi-upright position I told you here, because with MI you can get a cardiac failure, left ventricular failure, congestive cardiac failure. They might find it difficult to breathe. That's why you rather keep it in a semi-upright position. Anaphylaxis is a very important situation. A severe life-threatening generalized hypersensitive reaction. There's rapid airway and breathing and circulation problems taking place. Skin and mucosal changes alone are not a sign of an anaphylaxis. Remember that. Skin signs are not just an anaphylaxis. They could be just an allergic reaction. But skin signs are often the first feature of an anaphylaxis. You can see this, angioedema, periorbital edema here, both eyes closed, and you can see the edema going into the cheek region, and then it might spread around the mouth as well. And you can see the urticaria on the back of the chest. And what happens is patient, as I said, patient say, I'm not feeling well, I feel warm and this and that. Then of course they collapse, they find difficulty in breathing, and it's like an acute asthmatic situation. If you listen to the lungs, you might hear the bronchi. So the most important thing is to give adrenaline 0.5 ml IM, not SC, not subcutaneous, not intravenous, IM. You can give intravenous if you are in an ICU, intensive care situation, or in a situation where you have a lot of facilities, you can give IV. You can repeat it after 5 minutes if the patient is not getting better. IM is better in the thigh, they say, so you can give a lot of areas of muscles. You can give in the deltoid, you can give in the tummy, rectus, but you can sometimes, some people give in the tongue, but I think thigh has a better absorption, lateral aspect of the thigh. You give oxygen, give hydrocortisone about 100 to 200 milligrams, IV or IM if you have an IV access, chlorpheniramine 10 milligrams to prevent any other sort of allergic reactions and responses, and you can also give an IV fluid challenge. Let's talk about hypoglycemia. In a diabetic patients, always think about hypoglycemia unless proven otherwise, because if you give insulin to a hypoglycemic patient thinking that the patient has hyperglycemia, you will basically kill the patient. So always think about hypoglycemia in a diabetic patient. If the patient is hyperglycemic, even if you give a bit of glucose, it's not a major deal, you can control it, right? So patient gets confused, they get nervous, they get a lot of sweating, diaphoresis, full bounding pulse when you feel the pulse, and they have pallor, so they get kind of pale appearance. And then rule of 15, you give 15 grams of carbohydrate and wait for 15 minutes and check the glucose level with a glucometer. Half a can of Coke or 1 tablespoon of sugar also has about 15 grams of carbohydrates or sugar. Give IV, if you have an IV line, 50 cc of 50% dextrose. If the patient is awake, you can give orally as well, you can give glucose tablets. You can also give IM glucagon as well, 1 milligrams, but it works only if there are stores of glucose in the liver only. It takes a little longer than glucose. Seizures. Now, seizure is a bit of a frightening situation again. Remember, epilepsy, usually patient gives you a very good history about epilepsy, aura and all that. Sometimes local anesthetic overdose can cause epilepsy. Hyperventilation can cause sometimes seizures. Syncope and brain hypoxia causes hypoxia can cause seizures. Usually, these syncope stops in less than a minute. Pulse is fast and they have a good volume of pulse. Cardiac arrest patients may also can get seizures, so therefore you have to keep an eye on the situation, check the respiration to rule out genuine epilepsy. There's a situation, that's what is usual, seizure is not a major problem. You leave the patient at a side so they don't get damage. They recover fine, not a major deal, but status epilepticus is the problem. There you get the seizure lasts more than 5 minutes, or one seizure within 5 minutes, more than one seizure within 5 minutes time, without gaining consciousness. That is a status epilepticus. It can cause brain damage and serious permanent damage to the brain. So in a status epilepticus, what you do, the most important thing is to give midazolam or diazepam. You can give buccal, you can give intranasal, or you can give, if we have PR, a device like this, diazepam, you can give per rectally as well. So you can give, so most important thing is to give a sedative like midazolam or diazepam, PR, buccal or transnasally. So seizure, suggestion of a seizure is patient gives a history of a seizure. They can have aura. What are automatisms? They do some repetitive movements, lips making like that, or they do some sort of movements. They are not aware of it. They are automatisms. And the convulsion are at the start of the episode. Remember, in a syncope, you can get convulsions because of the lack of blood supply, but that happens at the end of the event. In a seizure or epilepsy, it starts at the beginning of the event. It has a longer duration. It can have a post-ictal phase where they might urinate, they might defecate or vomit. They can have tongue biting. Right, acute asthmatic attack. What are the signs and symptoms of an acute asthmatic attack? Shortness of breath. They breathe very rapidly. They can't take a full deep breath. And you might even hear the wheezing. You might hear the wheezing, and they might have a cough as well. Tightness in the chest, hyperventilation. If in a bad situation they go blue, they get cyanosis, central cyanosis, peripheral cyanosis. Usually the central cyanosis is the worst thing. And they get a tachycardia. And if you listen to the chest, you will hear rhonchi. Remember, in a worst scenario, there may be no sounds at all. There may be no sounds when you listen to the chest in a bad asthmatic attack, right? And the other thing is, if you ask the patient to talk, and if the patient can't complete a sentence, that is also bad situation there. They can't maintain their breathing. Expiration is what is affected in asthma. So they may not be able to complete a sentence. What you do is you need an inhalation like salbutamol inhaler. And if you have a spacer like the top picture, that delivers enough medicine to the chest. If you don't have that, you get a paper cup and make a little hole and then ask the patient to hold the paper cup, and you can spray it onto the other side of the paper cup. You can use the inhalation device, the spray. Adrenal crisis is acute hypotension in a patient who has been on usually high dose of steroids. Not a little amount of steroids, high dose of steroids. And they don't respond to any acute stressful situations. What you do is their blood pressure goes down very rapidly. You place them supine, give oxygen, give IV fluids, get an IV line and IV fluids. Most important thing is to give hydrocortisone about 100 to 200 milligrams. If not, you can double the daily dose and continue for a few days. And make sure you assess the patient these patients who have a history of adrenal crisis. But having said that, I have never seen an adrenal crisis for the 30 years of my practice. It is probably overstated, but you just have to keep an eye on it. So in summary, you need to be prepared for this situation. Don't panic. Have protocols for all these situations, and you can put it in your surgery and train your staff. You practice these scenarios on a regular basis. Have an emergency trolley. Check regularly. Remember and know where to ask for any emergency services, how to call them and the numbers and everything. Be prepared. Detect early warnings. Take a good medical history and update the medical history every visit. The best handled medical emergency will always be the one that never happened. Thank you very much.